Hi, I'm Dr. Tim Kosinski, and today we're going to demonstrate a atraumatic extraction of a non-restorable bicuspid tooth. You can see we had root canal treatment and significant bone loss around this tooth. So what we're going to do is use the golden physics forceps, which is a technique that we use to remove the tooth without putting a lot of tension. The instrument consists of two components, a beak and a bumper. The beak is the working end of the instrument and engages the palatal aspect of the root 1 to 3 millimeters subgingival. The bumper is not the working end of the instrument, rather it just serves as a fulcrum to allow us a center of rotation. So the beak is engaging and placing tension on the palatal aspect of this root. That tension is going to create a physiologic response which will create an enzyme which will break down the periodontal ligament. When the periodontal ligament is destroyed, the tooth will then disengage up and out of the socket. The instrument is not intended to remove the tooth in total, rather it's intended to luxate the tooth 1 to 3 millimeters. We'll then simply take a tooth delivery instrument, a bird beak type of instrument, grab onto the tooth, and simply rotate that tooth up and out of the socket. The intent here is to maintain the facial plate of bone as possible, and also the interseptal bone. The interseptal bone is what holds the interdental papilla in place. So we're simply able to remove a tooth atraumatically. In this situation, we grafted the defect after curetting extensively. We want to remove any granulation from the site. We want to remove any dark blood, purplish blood from the site. And then we're simply placing this graft material into the socket site. The area will then be sutured closed. I have just two cross-linked vicryl sutures, and you can see immediately post-operatively what this material looks like. You can see that there is a little bit of radiopacity, not so much at the apical portion, but this is going to fill in with bone over a period of time very, very well. 1 week post-operative, you can see the epithelium is already granulating through, and you can see just a little bit of the graft material still in place. After 4 months, you can see a definite change in the quality of bone present. The osteoclasts eat away this material. It's a calcium and phosphorus in a bovine Achilles tendon matrix, and you can see that the osteoclasts are actually eating away the synthetic material, and osteoblasts are laying new bone. We now have a site that is acceptable for a dental implant 4 months after surgery. Here we're going to look at the site, evaluate the site for our Han dental implant. A Vatek CBCT analysis is done, and it allows me to visualize the amount of bone that I have available in that site. And also you can see the quality of bone. You can see how the site was grafted, and we do have formation of new bone over a period of time. So we can virtually place the implant using the software and determine which type of implant and the length and width of the implant that we potentially want to use. Now, in a two-dimensional determination of this implant placement, I will simply take a ball bearing of known diameter. We picked this up from Salvin Dental. The ball bearing is 5 millimeters in diameter, and we'll take some orthodontic wax and we'll simply place the ball bearing in the wax and take a simple DEXIS radiograph. At this time, we can then just do a relationship. We can measure the diameter of that ball bearing using our DEXIS software, and I'm sure most radiographic software has the same. We're calibrating the ball, so we're simply measuring the diameter of the ball using the software, and will ask us what the diameter of that ball bearing is. We'll say 5, we'll say OK. Now we have a direct relationship. We'll then do a quick calibration. of a single site, and we can determine how much vertical height we have. So I'm going from the crest to where I think maybe the floor of the sinus is potentially, and you can see we have almost 9.5 millimeters of bone available. One of the systems that I like to use for anesthesia is the Anutra system, and this is a buffered anesthetic system where it will take conventional lidocaine and mix it with sodium bicarbonate. The reason our injections hurt so much, or one of the reasons why our injections hurt so much, is that the anesthetic is very acidic, like a pH of 2. And when we simply buffer with sodium bicarbonate, we can increase the pH of the anesthetic to physiologic amount, which is 7.2. And this allows us to give a fairly innocuous injection, fairly painless injection. And I would probably say about 80% of my patients notice a difference. So here we're simply using the instrument, clicking and drawing out our anesthetic, our lidocaine and sodium bicarbonate. It's just a prepackaged system. We'll shake it, and then we have a disposable needle. And we will simply dry the site, and we're not going to block this area at all. I'm just going to infiltrate into the vestibule and kind of walk my needle up the ridge to the palatal. Here I'm just going to drip a little anesthetic onto the site, and you can see I use no topical in this situation. I will simply drip and wait about 10 seconds and inject. And about 80% of my patients don't experience any discomfort with this injection. I'm simply going to take my needle and walk up the ridge to the palatal area. And what I want to do is basically blanch. Now, when I'm doing this too, I also want to look at the mucogingival line to see where the attached gingiva is. And here it's apparent that we do have plenty of attached gingiva on the facial aspect of the crestal ridge. Another way of determining the amount of width that we have is four-man CT caliper. And we'll simply, after anesthesia, we'll just simply take this caliper and measure the horizontal palatal facial aspect. And here you can see we have nearly a centimeter of width, which coincides very well with what we saw on the CBCT analysis. The Hahn surgical kit is just an exquisite kit. It's very simple. And what I like most about it is many other surgical kits that we've used have single burrs with marking on them. And I have found in my education that doctors often have a very difficult time seeing the lines. And I always say in my lectures, I can teach you where the lines are, but I can't teach you to see the lines. So what the Hahn system from Glidewell Dental Lab has done is it's provided us a system of pre-measured burrs, or the burrs are a different length and different diameters. So it's very exquisite, very precise. The Hahn implant itself is pre-packaged sterilely and has all the measurements and recording devices. We have a torque wrench, a single-handle torque wrench, which will measure the amount of torque that we will use in a certain situation. Here we're using a handpiece. I have many different motors, but in this system we're going to drill at 800 RPMs at 10 Newton centimeters. Here's a drill extension that will allow us to make our initial penetration using a 2.4 diameter burr. The burrs are 1 millimeter longer than the implant itself. You can see I've actually marked the facial aspect of the adjacent teeth, and this is simply giving me field goal posts to look at to help me angle mesial distally correctly. Buccal lingually, or buccal palatally, facial palatally, we want to place the implant basically in the center of the central groove area. So I do use a marker a lot to help me in determining the correct position of the dental implant. After we have anesthesia of the soft tissue, I will simply take my 2.4 diameter burr, kind of lining up the field goal and simply penetrating through at 800 RPMs just to establish depth. I'm then still simply taking that burr out of the handpiece, and I'm going to take a digital radiograph stand up, look at the position buccolingual, and I'm looking at the radiograph and evaluating my position. I like the implant to be pretty much center, mesial distally, and I'm looking at the dead space or the dark space, mesial and distal to that burr, and you can see that we're fairly in good position. It looks like we could have good emergence profile. You've heard me say that implants today are prosthetically driven, and so all my surgical applications are intended to improve or work upon the final smile design and emergence profile of that implant out of the set implant that's placed into the jawbone. So you can see I've just gone a little bit into bone, and I'm happy with my angulation. I'm then going to take a punch and simply remove the soft tissue off of that crest of the ridge. And the reason why I want to remove this soft tissue is because with my other burrs, my longer diameter burrs, wider burrs, I don't want to place the tissue into the socket site. And so we're simply taking our punch and going to rotate a little bit and remove that soft tissue easily and cleanly. I'm taking a tissue forceps, and you can see we have a soft tissue tag. We have a nice clean incision. Now I'm going to widen the osteotomy with our 3.0 diameter burr, and these are preset 8, 10, 11.5, 13, 16 millimeters, and I can measure the soft tissue and determine the depth that I want to go into the bone. Angulation has been predetermined by the 2.4 diameter burr, and to check it again, I'll reset that pin or reset that burr in the mouth and take a radiograph, mesial distally, buccolingually. We look like we're in good position. And I'll simply take a radiograph to see that I am at the floor of the sinus. I'm looking at soft tissue. We have about 3 millimeters of soft tissue. And I'm simply going to widen that osteotomy site with the 3.5 diameter tapered burr. Again, we're going at 800 RPMs, and I'm going to the floor. I'm simply going to the floor, measuring again, taking a radiograph, and you can see I'm at the floor, what I consider to be the floor, but the burr is not completely at depth, which is fine in this situation. I'm now going to widen to the 4.3 diameter tapered burr, and again, these burrs go very, very quickly. It's really a 5-second procedure because all it's doing is widening that bone. And we're going to do the same thing, take a stop and take a radiograph to make sure we're in correct position. And look at the bone that's harvested from that site. Again, looking mesial distal, buccolingual. We're right in the center of the central groove. We have good attached gingiva. And again, we're right at that floor, so I feel very comfortable. Now I'm going to place my implant. So here I'm going to slow my speed down to 15 RPMs at 25 Newton centimeters. And you can see how slow that is. These implants are 1 millimeter shorter than the drills. Okay, we talked about that in the lectures. And we're simply going to very, very carefully, very slowly engage the implant. And I want you to stop right at tissue level. We're not going to go subgingival. We're going to stop right at tissue level. Now we know the implant isn't completely seated, right? You can see that. But now we're going to take our torque wrench, and we're going to determine the amount of torque we have in this situation. Here it's set at 25 Newton centimeters, and about one complete rotation, 360-degree rotation, or 4 quarter turns, we're going to get about a millimeter in depth. So this allows you to have really nice control and positioning of the implant. So here we're getting torque, so I'm increasing the amount of torque, and we ended up at 45 Newton centimeters, which is pretty amazing. And you can see my position of my dental implant is right at the crest, right at the floor of the sinus. We may have elevated that sinus floor slightly. Here we have a closure cap, and then because we got to 45 Newton centimeters of torque, which is a tremendous torque, we can use a taller healing abutment. The healing abutment is a wonderful instrument because it eliminates the second stage surgery. it will allow it'll penetrate through the soft tissue. The soft tissue will heal around it and will eliminate the need to expose the implant that we would have to do if we had placed a cover screw and the epithelium was allowed to regenerate over the top of the implant. So we're taking our healing abutment, and you can see immediately post-op we have great attached gingiva, very little bleeding. The healing abutment is just slightly above the tissue, and the tissue is going to heal wonderfully in that site. Immediately post-op and post-operative radiograph shows a nice position of the implant to the floor of the sinus, right at the crest of the ridge. Now we do have this machine collar with the Hahn system, and that machine collar is a very, very important part of the system. Dr. Hahn, who created several implant systems in his career, found that a machine collar allows for biologic width to be established, and if we do get some bone loss in that area, the soft tissue responds very well, as opposed to having bone loss onto the process or roughened surface of the implant itself. So we will torque that healing abutment to 25 Newton centimeters. That eliminates it coming out of the mouth. Oftentimes, if you hand tighten, the tongue will find that area and loosen it. Patients will call and say, I lost my implant, but obviously that's not the case. So if you're able to torque to 20-25 Newton centimeters, that healing abutment is not going to come off. You can see our post-operative CBCT shows really nice position of that implant in solid bone at the floor of the sinus, and I feel very comfortable with our surgical application.